Door to needle times have changed quite a bit at the Grey Nuns for the last 12 months. We've trimmed off some of the extra minutes by getting processes that are enabled by the nurses faster so we can get things moving quicker. We've had more notification from EMS in the last 12 months, allowing us to know that there's questionable stroke or a hot stroke coming in. We've enabled work with other departments within the emergency or within the hospital to allow us easier access to get that door to needle time down. That day, the patient presented complaining of hypertension, and that the patient was more confused because of their hypertension, because they're hypertensive at home. I think it was like 170s or something. When I was investigating with the patient quickly at triage, I identified that the patient was confused, but they also noted to have a little bit of a facial droop and slightly didn't seem to be responding appropriately, which point in time went down a different pathway and felt more of it was an acute stroke. I asked a family member to quickly grab a wheelchair, and at the same time they were grabbing the wheelchair, just quickly signed off saying that the patient has acute stroke, put them in the wheelchair, triaged it, finished triaging, sent it to admin, told the family member to go over to administration and finish making a chart, wheeled the person right into the department, noted that there was a bed available in one of the acute areas, put the patient in the bed, had tapped the neurologist and one of the COs who happened to be having a consult at the same time near the desk. Told them I think it's acute stroke. These are the signs and symptoms. This is what I've triaged. This is how it's going on. Told them to go see the patient, please and thank you. At the same time, asked one of the nurses who was in the acute area to just get ready. Don't even worry about the IV right now. Get ready to take the person over to CT. Picked up the phone to CT, dialed them, let them know. Advised them we have a patient. He has not yet finished registration. Please process as unknown, create a patient event history. I will provide all the information about the patient and their identity once I have the chart available. But if I could do the CT stroke protocol, doctor verified, said, yep, go ahead with that. We sent the patient with the nurse within minutes, like a minute, right over there. The neurologist followed along, if I remember correctly. As they were walking back, he came back first thing. He said, yeah, we're going to TPA. Other nurses, we just kind of swarmed. We got the TPA started, get ready to go. As soon as they came back to the room, tossed an IV in, gave the flush. The crucial thing about that one there was that neurologist was already on the floor. So because we had neurology already on the floor, we didn't have to do the phone consultation to say, hey, we have a suspect of hot stroke or we have a highly presumptive hot stroke in the department right now. We need you to come see, or we're doing a CT. Because they were already on the unit, we could easily identify, yes, this is what it looks like. We can get the CT just ordered within a couple of minutes. We just send them right over. But the fact that the neurologist was on floor, he could go walk over, see it at the same time, and come back and say he has a disposition saying, okay, administer TPA now. Challenges sometimes for fast door to needle times. We can get the door to CT time now is highly improved, especially with the EMS, because we can just have the EMS bring the patient in and go. I'm seeing sometimes once we've consulted for the neurology, the primary physician emergency will review the CT. He or she may not be sure whether or not to give the TPA. So let's say, okay, we'll refer to the neurologist. Sometimes the neurologist may be, say, at home or so. That's 10 minutes, but we just usually pick up the phone and let them know prior so they come in. Some neurologists, they'll sit there and they'll look at it a little bit. Sometimes it really does add 15, 20 minutes because some of them will be saying, well, they'll weigh the situation a little bit more. So there are some times where the door to needle times increase exponentially because of them trying to figure out the disposition of what they're going to TPA or not. There are some times with the high acuity and no beds when we have an inpatient, say for instance 20 inpatients, so 20 beds are currently occupied by inpatients of the hospital. It means we're only working with 6 beds within the department, and if we have high acuity, it makes it a little harder, but we can easily we pull someone out, put them in a hallway to get the acute stroke in. We'll make it work and we'll find a spot for them. To be consistent with these times, I feel that we as a collaborative team at the Grey Nuns all need to be on the same page, all need to have the same drive. We all need to have the closed loop conversation. We all need to drive what's going on with the patients. Each instance where there's a patient who's questionable to have a stroke or presents with a hot stroke, that we all need to have the onus, drive it, get it seen, make sure it works, and always have that same feedback and that loop feedback and saying this is what would happen, this is what it did. And every time we have an issue where we have times that are not within our window, or times when they're short little 30 minutes, we need to make a quick notation to Darla, to anyone else, and say these are what happened during this episode. Here's some things identified that we had for longer periods of time. And that way we can review it and go back and look at it again. Currently with endovascular therapy, not all of our CT techs, if I remember right, can do CTAs, and they're only there for certain periods of time. Don't quote me on that one. But a lot of times we can get them to the CT room, and then we'll have them done the CT and back to our bed before the neurologist is even on unit. So we'll have them back in bed, everything else done, waiting for neurology to figure out what their disposition is. A lot of times we'll get the TPA, then they'll say, okay, do we want to do CTA here, or do we want to set direct transfer to you for the endovascular therapy? Sometimes they'll do the CTA here, okay, well, it's questionable, let's just send them to you. So there is sometimes a lengthy period because of the questionable, what do we do CTAs here, to directly send them over there. I like the fact that we can have, if a nurse can go with a patient for direct TPA administration, that is wonderful. That would exponentially increase the patient's outcome, exponentially increase the fact that they won't have any of the long-lasting effects of the stroke. The one thing I would always want to make sure though is that a physician, either be a emerge physician and or neurologist, would have to be with nurse, even just not for the fact of double checking the medication, the TPA, but to assure that saying, okay, at this point in time, give the TPA. More so to make sure that no one's just kind of going there giving TPA when the patient shouldn't have received it. But in some instances, it's better some care than no care. For other sites, if you're within the big cities, all I stress is basically as soon as you identify a person who has signs and symptoms of stroke, whether it be an acute TIA, whether it be something that seems a little off, get the CO to see as exponentially as fast as possible with EMS, if you can, whether it be in a hallway, whether it be on the side. Just get them assessed, get them seen. That way someone else can see it, and then they can dictate on getting the CT. I don't know what their protocols in some of the hospitals are. Sometimes we just kind of get things going and then get the CO to see and sign off on it. And other sites where the telehealth is and they're finding with the rapid, I'm finding they always have that neurologist on call. If they have one who's definitely identified as that, get that CT, and as soon as they're at the CT suite, I'd say phone them and say, hey, CT is being done right now. It should be loaded up on your system. Can you review it in a minute or two? That way they're on the phone only for a short duration, at the same time they can review that and they can make that decision there. The communication loop is the biggest key. You need to communicate with everyone involved, because you need to communicate with the CO who's on for the emergency. That way he can also communicate with you what he wants done. You need to communicate with the neurologist as soon as possible, because they're the one who's going to take lead after he comes in, and or if he's on the phone, he's the one who'll take lead for the while there. The emerge CO will be the one who's treating symptomology if the patient happens to deteriorate, or if he has adverse effects, or if anything continues on with that stroke, such as seizing, the nausea, the vomiting, all that.